So thank you for joining us at the virtual Mark Twain Library. We're very delighted to be co-hosting this program with the Readings Commission on Aging. And so I'm going to turn things over to Sarah Cummings, and she is with the Commission on Aging, and she's going to share a little bit about the Commission with you.
Good afternoon. The Commission on Aging is very pleased to collaborate with Mark Twain Library and RVNAhealth on this very important issue. And I'd like to say just a few words about the Commission on Aging. We're a town-appointed agency established to review the policies on all matters that concern our aging population. We work very closely with the Heritage Center and Social Services and with the First Selectmen, and we recommend services and activities that could benefit this segment of our population. Our meetings, which are now virtual, are open to the public, and we meet the second Wednesday of every month at 9 o'clock in the morning. The Zoom link can be found on the Town of Reading website under meetings and agendas. And we would invite you to join us whenever you're available. I will put these links in the chat box for everyone's convenience. And I thank you very much. Passing it on now to Mary Dale Lancaster, the Executive Director of the Commission on Aging.
Well, thanks so much, Sarah. Hi, this is Mary Dale Lancaster, and we are so delighted to have RVNA here. RVNAhealth has been steeped in the procurement and administration of COVID-19 vaccines for the last several months, and they and we are happy to share information and insights. So the presentation today is going to have 3 segments. The first segment will be with Dr. Kay Hale, who will be speaking on the science of COVID-19 vaccine. Dr. Hale is the Associate Medical Director of RVNAhealth Hospice Services, and she will be getting into how the various vaccines, including the newly approved Johnson & Johnson vaccine, works against the virus and its variants, and how it was researched and developed, and what you can expect from these vaccines. Next up is Laura Schulman-Cadera, who will be speaking today about the COVID-19 vaccine operation. Laura is the Director of Community Health and Wellness at RVNAhealth and holds a Master's in Public Health. Laura will be covering the operation and logistics, how the vaccine gets from the manufacturer to your arm, how the state of Connecticut vaccine distribution works, and about VAMs and other options for scheduling your appointment. That's something we're all very interested in. And the third segment of the program is with Doug Hartline, Reading's very own Director of Health. Doug will be talking about what the town is doing to support residents in receiving their vaccines. Okay, and there will be time for questions at the end. And with that, I'm going to turn it over to Dr. Hale.
Thank you very much. Go ahead and share my screen. Good. Okay. Good. So thanks very much for the opportunity to partner with the Mark Twain Library, and Laura and I are very happy to be here to help and explain some of the information that at times can be very, very daunting. Before we begin, I think, Laura, you're going to display our first poll, which is a question about who on the call plans to get the vaccine, whether they're not planning to get the vaccine, or whether they're on the fence or unsure. So if you are dialed into the Zoom and you've got the capability, there should be a poll projected on your screen that gives you an option to click yes, no, or unsure / on the fence. Are you planning to receive the COVID vaccine as soon as you are eligible and an appointment is available? I don't see folks registering answers. So I'm not certain that the poll is actually live.
We have about 87%.
Oh, you do? Okay.
Yep.
It's not showing on mine. So you'll have to tell me the answer.
I will tell you. So we're 87% of people have answered. We're
Great.
waiting for about, oh, here we go. Waiting for a couple of more people. We'll give them another few seconds.
Thank you, Laura. For some reason, it's not showing for me.
No problem. So we're at 90% now. I'm gonna end the poll And we're actually 100% are planning on getting the COVID vaccine as soon as they're eligible and there's an appointment.
Wow, that's amazing. Great. So it looks like we don't have anyone that's concerned about, or maybe you have some concerns about safety, and we'd like to allay those concerns and of course answer any questions as they pop up. So let me dive in here and start to explain, what is the origin of most people's concerns when it does come to getting the vaccine? And even if you're sure that you want to get it, that doesn't mean that you don't have some reservations. Something called vaccine hesitancy is an actual known condition, and it's normal. Many people are concerned about this new type of vaccine being used on them and feeling like they're a guinea pig. There's a lot of concerns out there that because the vaccine came to production so quickly and came to approval so quickly that in fact it was rushed and maybe there were corners cut in the approval process. Of course, safety and side effects are always a valid concern of any vaccine or drug that is approved for use and authorization in ourselves. Other important questions to know about is, what is emergency use authorization? What does that mean? And of course, the be all end all question is, how effective is this vaccine that we all plan to get? The first COVID vaccines, as many of you probably know, were the mRNA vaccines. Those were the first two approved COVID-19 vaccines. One was by Pfizer and one from Moderna. The third approved vaccine, just approved last week, was the Johnson & Johnson vaccine. So the first two are mRNA-based vaccines, and we'll talk a little bit about what that means. And the Johnson & Johnson one is a slightly different delivery mechanism. It's a recombinant adenovirus vector vaccine. The AstraZeneca vaccine, which is still undergoing phase 3 trials, is also of that variety. And what's important to know is that all of the currently approved vaccines and the ones that are actually ongoing for development right now, none of them actually contain the virus that causes COVID-19. So in no instance are we injecting the actual virus into anybody to vaccinate them. To understand this a little bit better, I'd like to review with everyone the typical vaccination methods. A live virus vaccine where we actually do take the virus and introduce it to someone's body is pretty unusual, but that is the intranasal flu vaccine. It's not all that widely used, but that is that type of mechanism. A live attenuated or weakened virus, the measles, mumps, and rubella vaccine series that many of us received as children, or maybe our children are getting them now, is essentially a weakened version of each of those agents before it is injected to then stimulate an immune response. An inactivated or heat-killed virus is what we typically get with our flu injection vaccines or hepatitis A vaccines, as well as the polio. In addition to injecting actual weakened or killed virus, some instances we inject the weakened toxin that some organisms produce that make us sick if we're exposed to them. And that is the case with the diphtheria and tetanus vaccine components. The more common one, more common one that we talk about is the subunit or conjugate vaccine delivery method. And that would be the pertussis, H-flu, pneumonia shot, and also the shingle shot. So the subunit and conjugate vaccine, what that means is we basically taken bits and pieces, important pieces of the organism of interest that we want to protect the individual from, and we package that into a vaccine and then deliver it. And it's those bits and pieces that then our body will recognize if we're exposed to the organism or the virus or the bacteria down the line. So again, we're not injecting the whole bacteria or virus, rather important bits and pieces of it that our immune system will then recognize and flag if we're exposed to it down the line. This is a graphic of the coronavirus, and what I'd like you to see here is this red spaghetti-like material in the center is the genetic code or mRNA of the coronavirus. This genetic code is what goes on to produce these spike proteins, which a lot of us have seen graphics of or have heard about, the spike protein, which lines the outer surface of the virus. This spike protein is what grabs onto the cells in our mucous membranes or in our lungs, gains entry into the cells of our bodies, goes on to replicate, reproduce more and more and more virus, which we can then shed or go on to make us sick. So again, when we're talking about the different types of vaccines, we're not injecting this whole organism. In the case of the Pfizer and Moderna vaccine, we're taking a stretch of this genetic code and packaging that into a vaccine. Or in the case of the recombinant adenovirus vector vaccine, it's still, we're taking a short stretch of this mRNA, which codes this particular bit of the virus, so that our bodies, if we're exposed to it down the line, recognize it as something foreign and to be attacked. The mRNA and recombinant adenovirus vaccines, the technology behind both of these is not new. With respect to the mRNA vaccines, the technology for building mRNA-based therapies has been around since the early 90s, and there are actually currently 4 mRNA-based drugs approved by the FDA for various illnesses and diseases. What's appealing about mRNA is it has a capacity for rapid development. Rather than growing or culturing virus or bacteria in the lab and then chopping it up into those important bits and pieces and packaging that into a vaccine, with mRNA, we basically amplify that stretch of genetic code in a machine in the laboratory, and we can make millions and millions of copies of that, which unfortunately then do need to be packaged. And in the case of mRNA, it is very fragile. So what we're packaging, what Pfizer and Moderna are doing is packaging these stretches of mRNA into lipid nanoparticles, and a fancy word, I think, for a soap bubble. And what that does is allows the mRNA to adhere to our cells and gain entry, where then the mRNA does not enter our nucleus or incorporate with our DNA at all, but rather sits in an area of the cell that is responsible for churning out what that genetic code wants me to make. So it turns that mRNA into little bits of spike protein, which then tell my body that next time I see this spike protein, this is what you need to attack. We also are mostly aware of the cold chain required to maintain stability of these mRNA vaccines. So yes, there's upside in the capacity for rapid development, but there is some downside. With regards to the recombinant adenovirus-based vaccine, the Johnson & Johnson vaccine, for example, what we're taking is a common cold virus, slightly altering its genetic makeup to have part of the coronavirus mRNA encoded in it. And it's a similar type of thing. The virus then delivers this mRNA into our cells and produces that spike protein. The virus, the adenovirus vector, does not replicate in our bodies, so it cannot make us sick. This delivery method is a bit sturdier and a bit more robust than the naked mRNA, if you will. So it's appealing in the sense that it doesn't need the deep freeze that we're accustomed to with the Pfizer and Moderna vaccines, and they're a little bit more shelf stable, so to speak. These types of vaccines are also not new. They've been used for the SARS and MERS outbreak, and mostly in research capacity for Ebola, HIV, Zika, and something called respiratory syncytial virus that we see in children. So by August this summer, there were already 30 clinical trials underway to develop a SARS-CoV-2 vaccine. The mRNA vaccines essentially won the race because the technology to produce mRNA already existed with these machines in labs. The genetic sequence of the coronavirus was known very, very early on, and our ability to sequence genomes is something we've been able to do for many, many years. The pace at which the phase 1, phase 2, and 3 trials were performed, they were not cut short and they weren't sped up. Rather, they were done in what was more of a continuous or parallel fashion. What also helped was the large amount of government funding. And in actuality, a large amount of vaccine was produced before FDA granted emergency use authorization. So the way I look at this is rather than a stack of papers sitting on someone's desk, rather than the newest thing getting pushed to the bottom and kind of being pushed to the bottom of the workflow, at every step of the game, the approval process and the safety monitoring for everything having to do with vaccine approval was kind of put on the top of the stack. And that was just the nature of the need for something when we were dealing with a pandemic where many, many people are dying, that this received the attention it deserved. And it went through, with greater speed. So if you compare the approval path for traditional vaccines versus mRNA, you can see the stages each took less and less time. From the preclinical to the phase 3 and approval and manufacture distribution of these vaccines took much less time than is typical. And then again, is not because we cut the corners, rather we just said, we need to pay all of our attention to this particular endeavor and really streamline the process. Emergency use authorization, and this is a term you'll hear when you go to get your vaccine, you will be given the EUA fact sheet for whatever vaccine you do receive. It's an authorization, and it's based on the need to use a vaccine or any therapy quickly to save lives during a public health emergency. Again, it is not an expedited process, and we have not eliminated steps to ensure safety. And the FDA in the end needs to assess what are the known and potential benefits of the vaccine versus what are the known and potential risks. The information then presented goes through 2 independent advisory boards, which review all of the data and make the clinical recommendations for EUA. Again, I can't reiterate enough that it does not mean that any corners were cut or study trials were cut short, just that with all of the really focused effort of many different agencies involved, the work was able to proceed much more efficiently. This is a snapshot of the 3 trials that were presented for EUA on these various vaccines. So the Pfizer, Moderna, and Johnson & Johnson phase 3 trials. This is the published data. It shows you the number of participants in each trial. It's a robust, typical number of people. So it wasn't as though we didn't enroll enough folks than we typically would. 2 of the trials happened outside of the US, but also included the US. The Moderna vaccine only took place in the United States. I always think it's interesting to look at the demographic distribution of the study participants, just so that I can say, okay, someone like me was included in this group. The age cutoffs for each of the trials was a little bit different, but they did all contain a good population of older individuals. With regards to the efficacy, I think a lot of us have heard these numbers in the press. For the Pfizer and Moderna, this is again after 2 doses, the efficacy is 95 and 94%. For the Johnson & Johnson vaccine, after 1 dose, there's a range here of efficacy from 66 to 85%. And the reason for that range is if they removed the people who were the sickest of the sick, the efficacy was actually higher than if you took folks who just had your kind of run-of-the-mill symptoms. So if you included all comers, the efficacy was probably closer to the 65 to 70%. But if you said, you know what, I just want to look at how we prevented really, really severe illness or death, then the efficacy was closer to the 85%. With regards to adverse events, across all 3 trials, they were similar, and most common were injection site pain, fatigue, headache, body aches, chills, or fever. And at the bottom here, I have, just by way of comparison, is the efficacy rates for a lot of our other common vaccines. So for the measles, mumps, rubella, there's 93, 78, and 97% efficacy respectively. For polio, the efficacy is 99% after 3 doses. Shingles, 90% after your series of doses there. For flu, I think as many of us know, the efficacy is a little slightly better than a coin flip because of the variants that we face and how the flu virus changes year to year. So 60% efficacy on flu virus average. For the pneumonia shot, depending on the type you get, may range from 60 to 70% efficacy. So these are good efficacy numbers relative to many of the other vaccines we see. With regard to safety, and this is a big concern for many people, and appropriately so, there's been over 75 million doses given in the US to date. And along with the launch of this vaccination program was launched probably the most intense and comprehensive vaccine safety monitoring process in the history of the United States. There have been several different methods used to track the safety of these vaccines. The first one is something called the Vaccine Adverse Event Reporting System, or VAERS. This is something that typically a healthcare provider would report to if a patient of theirs experienced an adverse event. The cases here are then reviewed by the CDC and FDA to look for causality, which in many cases is impossible to attribute. There's also something called vSafe, which many of you who plan to get your vaccine or have gotten your vaccine, I would encourage you to register for this mobile application on your phone. This is a self-reporting adverse event reporting mechanism. So far, we've got about 10% of vaccine recipients registering for it. A lot of pregnant women, which as many of us know, weren't included in these studies, are registering to report their adverse symptoms that they're experiencing after the vaccine. So even though this, some people who are fearful of big data, this is going to be actually a very rich source of information for us as healthcare providers for what people are experiencing after they're receiving the vaccine that may not have been gleaned from the phase 3 trials. There are also medical research centers and large healthcare organizations that are mining their data sources for any patterns of adverse events. And I think what's important to know by and large is that bad medical things happen all the time. For example, heart attacks, strokes, cardiac arrests. And what we're seeing, if they look at the population as a whole, is since we've started vaccinating people, we're not seeing an uptick in the numbers of these events happening. So, they're going to happen in the background. So many times people will say, well, I heard my Nana's roommate at the nursing home had gotten the vaccine and 5 days later she died. More than likely, this individual died from natural causes and wasn't actually related to the vaccine because the odds are just better that it wasn't related. So adverse events, we talked about the VAERS system. It's good because it can help us to detect rare events, but again, difficult to assign causality because you're reviewing a case kind of that has happened weeks, sometimes months in the past. To be considered a serious adverse event, it needs to result in death, life-threatening illness, hospitalization, permanent disability, or a congenital anomaly. So if a pregnant individual or someone who did get pregnant had gotten the vaccine and that baby was born with an abnormality, that would be considered a serious adverse event. I think naturally we won't have any information on that type of serious adverse event for some time because of just the timing of the vaccine. So the MMWR is a publication from the CDC that reports on statistics and health-related matters. And this was a publication from just published last week, and it looked at just the 1 month period after vaccination was launched. For that 1 month period, there were almost 14 million doses administered. And from this VAERS or vaccine adverse event reporting system, there were almost 7,000 reports of adverse events. The vast majority of these, 91%, were non-serious and were typically headache, fatigue, and dizziness. Those were the most common. 640 were qualified as serious. Remember, those were the ones that death, life-threatening illness, disability, or hospitalization. Of those 640, there were 113 deaths, 65% of which occurred in long-term care facility residents, which included folks who were on hospice or had comfort level measure of cares. There was, again, no causal relationship suggested upon review of these deaths. Merely these folks were expected to die, and it just happened that they had gotten their vaccine in a period of time before they expired. With regards to rate of anaphylaxis, we'd heard a lot about that. 4.5 per million doses are associated with anaphylaxis. And I have here in parentheses the range of anaphylaxis that occurs with flu, pneumonia, and shingles vaccines. And you can see that the anaphylaxis rate for COVID kind of lies smack dab in the middle there. When folks get the shingles vaccine, that can occur in 9 to 10 per million cases of anaphylaxis. The study that was published at the end of January, reviewing all these cases of anaphylaxis, there was a slightly increased rate with the Pfizer over Moderna. For the individuals that did experience these anaphylactic reactions or severe allergic reactions, 80 to 86% had had a history of allergic reactions themselves, or 24% had a history of anaphylaxis itself. And that could have been to medication, food, insect bites, intravenous contrast when you go get a scan in the hospital, or another vaccine. What's important to know is 90% of them occurred within 30 minutes of being vaccinated. So many of you will see when you go to get your vaccine, there's a minimum observation period of 15 minutes. If you have a history of allergies or anaphylaxis to anything, essentially, you will have to be monitored for 30 minutes. Most of these cases of anaphylaxis or allergic reactions are happening in women. I do want to note that because of this, all vaccine sites in their observation area are required to have the medical capability to manage an anaphylactic reaction. So that includes having EpiPens on hand, a nurse or a physician manning the observation area, a line to calling EMS so that if someone does need to be transported, they can be taken to the hospital in a timely fashion. So who should get the vaccine? Essentially, anyone who's at risk of disease from coronavirus should get the vaccine. That includes someone who maybe had coronavirus in the past, regardless of their antibody status. Certainly, if you have underlying medical conditions, most any of them put you at higher risk of severe disease or death due to coronavirus. So protecting yourself with the vaccine does make sense. Folks who are immunocompromised and or pregnant should also consider getting the vaccine after a conversation with their healthcare provider. Again, there weren't a large amount of individuals that were immunocompromised in the trials that were performed, and certainly there were no pregnant individuals. Hopefully we'll get more and more information about these types of individuals as the vaccination process goes on. And even if you do have a history of allergies, including anaphylaxis to foods or medications, it is not considered a contraindication to actually getting this vaccine. The only absolute contraindication to getting one of these COVID vaccines is if you had a severe allergic reaction with your first dose, you should not get your second, or if you have a known allergy to one of the vaccine components and something that's in it that some of us may have been exposed to before, is something called PEG or polyethylene glycol. It's typically something that's found in bowel preps. So if you had a bad reaction after receiving a bowel prep, that may set off an alarm bell in you. You may want to speak to your healthcare provider about whether you should go forward with the vaccine. When you get the vaccine, you absolutely should expect to feel something. At the very least, some injection site pain, fatigue, headache, muscle pains, chills, and fever are relatively common, particularly after the second dose if you're receiving the 2-dose series. Even if, as we start to roll out with the Johnson & Johnson vaccine, you should still expect to feel something. And what that is called is reactogenicity. And it's a desired effect of the vaccine. What it does is tell us, yes, my body has recognized this foreign material and is gearing up to generate a robust immune response if I'm exposed to it down the line. What's important to know about these reactions is that they are self-limited. They typically last no more than a day or two. And if you do normally take acetaminophen or ibuprofen, you can take those medications to relieve any of those symptoms. Again, the vaccine itself cannot give you COVID-19. With regards to the second dose, obviously for the Pfizer and Moderna doses, you are required to get the second dose because that is what the trials showed efficacy based upon, was a 2-dose series at 21 and 28 days respectively. You should get the same vaccine for your second dose as you did the first. And as I mentioned earlier, the only contraindication to receiving your second dose is if you experience anaphylaxis or an immediate allergic reaction to your first dose. There may be some questions that pop up about what happens if my second dose is delayed. And by and large, the answer is going to be, even if your second dose is delayed beyond that recommended time frame, you should still get your second dose. The current time frame in terms of anticipated protection with immunity to COVID-19 after getting your vaccine is about 1 to 2 weeks. The duration of immune protection is not clearly known at this point. We can only say up until about 6 months based on the trial results. Obviously, this information may change, and especially as variants pop up and we become more and more aware of what vaccines are still effective against the variants, this information may change. What is important to note is that the vaccines are effective at preventing moderate to severe disease. What they have not been proven to do is prevent you from contracting it and potentially carrying it and passing it on to other people. So hopefully after you have been vaccinated, those in the observation area are still reminding you that you do need to still wear a mask and socially distance until we've had a critical population of the United States that's been vaccinated and the disease incidence has dropped to a level to make that no longer necessary. What about the variant strains? By the end of the month, the UK variant is expected to be the dominant strain in the US. There are 3 variants that are very well known at this point, the UK, South African, and Brazilian. That's not to say there aren't many, many more variants lurking out there, and maybe even some that are homegrown that we're learning more about now. What we do know is that the variants are considered to be more easily transmitted. And the way they do that is that binding protein, that orange spike binding protein that's on the surface of the cell. Think about it as much more sticky. It adheres to our cells better. It's a better fit for the virus to get into the cells that it wants to infect. We have not seen any convincing evidence that suggests that any of these variants are more deadly or cause more severe disease than the original. And for what we know right now, the current mRNA vaccines are effective against these emerging variants, at least very much so for the UK and South African. The Brazilian variant, we're still a little bit unsure of. And what's also, we're seeing a lot of these vaccine manufacturers do studies about, well, what if we add another booster? Can we improve efficacy against these variants by adding a booster shot? So there's a lot of studies that are still ongoing to be sure that even though these variants inevitably are going to pop up, that we remain protected by some level from the current vaccines and potentially newer ones that are developed down the line. Yes, you still do need to wear a mask. Even once you are vaccinated, the vaccine prevents you from getting very, very sick or dying from COVID-19. It does not prevent you from potentially passing it on to someone else. I would encourage you to go to the CDC's website. There is an immense amount of information there. A lot of it is spelled out in very plain language and easy to understand. And of course, our local libraries always remain a great source of information. So I think with that, I'm going to pass it on to Laura.
Okay, thank you, Dr. Hale. I appreciate that talk as always. I'm going to just spend a little bit of time now talking about COVID vaccine administration in Connecticut. And we will have some time for questions and answers at the end. So please feel free to use the Q&A box. For most people, it's either at the bottom or the top of your screen, and you can enter any questions that you might have. So the objectives of my presentation are really to describe the process that gets vaccines from the factory to our clinics and into your arms, to define the categories of individuals who are currently eligible for a vaccine in the state of Connecticut, and identify ways for you to schedule your vaccine appointments if you live or work in Connecticut. So the first thing that you need to know are who the key players are in the vaccination distribution. So it starts, of course, with the pharmaceutical companies such as Pfizer, Moderna, Johnson & Johnson. The federal government would then purchase vaccine from them. They then allocate it to the different states and the territories. And then the states get to decide who within their state and which clinics are going to receive what quantity of vaccine. So the vaccine clinics are everything ranging from hospitals to local health departments, municipalities, local community-based organizations and health centers, pharmacies, urgent care, healthcare providers, federally qualified healthcare centers, so on and so forth. So this great graphic, I think, does a good job at explaining kind of what the different supply chain and what the distribution and administration looks like. It was developed by OWS, or Operation Warp Speed, and it shows you all the different components that go into manufacturing and distributing the vaccines. So at the top, we have our contracted Operation Warp Speed manufacturers. So everything, again, Johnson & Johnson, Pfizer, Moderna. And then right underneath it, I think this is a really important piece of the puzzle to understand. There are also the people who are developing the ancillary supplies and the personal protective equipment, or PPE, to actually administer the vaccines. So the vaccines are only as good as the materials that you use, such as the syringes or the rubber gloves or the masks and the gowns and the face shields that go along with it. So if we have 1 million doses of vaccine and they're sitting in vials, but we don't have any syringes, that is going to be a break in the supply chain. So that's an important thing to consider. So there are two processes that go on side by side. One, we're developing the vaccine and we're putting them into certain supplies like glass vials with rubber stoppers. And then at the same time, we're developing the supplies that are needed to actually administer the vaccine. We're bringing them to what's called kitting factories. So we're making kits of all the things that you need. Then the two have to come together and they have to get distributed out either through partner depots or directly to the different administration sites. So as a clinic, if we only receive the vaccine and we don't receive the other materials, we're not able to administer the vaccine. Or if we only receive the syringes and the gloves and we don't have any vaccine, we can't do the vaccine either. Things that are going to influence that, of course, are the weather. So we've seen a lot of that this winter. Every time that it snows, we're going to have breaks in the supply chain. So whether it means that FedEx can't deliver or UPS can't deliver the vaccine to us, or it gets delayed by a day or two, or it means that the airplanes that are going to fly all of the materials over can't go into the air because there's too much severe weather that's going on, or even if there is an issue in terms of the factories themselves. So what if the workforce gets sick and they're not able to report to work? So all the pieces of the supply chain need to be working in order for the vaccines to get ultimately to the clinics and then ultimately into our arms or your arms. So that's just an important piece to know. So how does this work? So each week, the federal government informs the state how many vaccinations they'll receive. Each vaccine provider or clinic must request the number of doses that they would like for the following week, and then requests are reviewed and allocated based on population data and vaccine resource data. So if you're in a town that has a lot of vaccines that were administered already, in all likelihood, the state is not going to give you a large supply for the next week. They're going to put it to a place that needs more people vaccinated. On Friday of each week, each vaccine provider or clinic receives the confirmation of the number of doses that they'll receive for the following week. So I'm going to just reemphasize that. So on Friday, we receive a note from the state, usually an email from the state, and they will tell us exactly how many doses that we're receiving on Monday or Tuesday. So vaccine appointments, you're going to notice, are not posted too far out into the future for most places, except for larger institutions, because we don't know how many vaccines we're getting until the Friday before the week begins. Moving forward, the state has already said that there is going to be a focus on clinics that are providing vaccines to towns with high CDC social vulnerability indexes, which is essentially a term that the CDC has coined that uses census data to identify communities that need support before, during, and after disasters. And it really considers a lot of factors. So usually these are areas that have high rates of poverty, unemployment, there might be limited access to transportation. The community might just not have as many resources as other communities. So we'll see in the allocation that where the majority of the vaccines are going to start going is really going to be these areas that are serving these populations. So the encouraging news is that the CDC, the White House has a COVID-19 response team, and they already know that these are issues with supply chain and that there are issues in terms of long-term planning. So they're already increasing weekly allocations to the states, the tribes, and the territories. They're also trying to give a longer-term projection to the states in terms of the vaccine quantities that they're going to receive, which means that they can then project to their clinics and say, okay, we know the state is giving us X million doses or X hundreds of thousands of doses. And that means for the next 5 weeks, your clinic is going to have this number of vaccines. And the more we know ahead of time, the more we're able to plan ahead of time. They're also working on getting more vaccinators on the ground and building more vaccination sites. So what does that mean for the state of Connecticut? How do we get a vaccine? So I'm going to start with a little comic relief here. So I like this little comic. It says, there's a gentleman at the end of the line. He says, "Excuse me, is this the line to sign up for the lottery that gets me on the wait list to take a number to receive my vaccine bingo card?" And then the gentleman in front of him says, "It was, but they just changed the procedures again." And for a lot of us in Connecticut, it feels like this is what's been happening. And then this one also makes me laugh. It's a couple, and they're working at one of those claw machines that you use to win stuffed animals. You see them at arcades and restaurants and so on and so forth. And in this one, it's a vaccine appointment claw machine. And the guy is just bringing that claw down, trying to get a vaccine appointment. But as you know, with these machines, you typically feel like it's in reach, and then it drops at the last second and you don't quite get the prize. So it feels for a lot of us like we're going after that impossible thing, and every time we think we're about to get it, it's not quite there, and that can be a very frustrating process. So why is it so frustrating? Well, eligibility varies from state by state, and it can change day by day. And this week is a good example of that, brand new eligibility. We'll go over that. So I'm going to launch another poll now. And what I want to know is, whoops, let me pull this up here. Launch polling. So beginning Monday, which was yesterday, which of the following people are currently eligible for a vaccine in the state of Connecticut? You should be able to choose all that apply, but if not, you can choose the ones that it's saying it's multiple choice. So hopefully you can choose all that apply. And our options are a 60-year-old with a pre-existing lung condition who lives in Connecticut, a 66-year-old with no pre-existing health conditions who lives in Connecticut, a teacher who lives in Connecticut, a nurse who works in a hospital who works in Connecticut, a 42-year-old veterinarian who works in Connecticut, a 57-year-old who's the primary caregiver for his 92-year-old parent, both live in Connecticut, and an 80-year-old who lives in North Salem, New York, but whose daughter lives in Connecticut. So I see about 50% of you are adding your answers. I'll give you just another minute. It's good to see so many people participating. Okay, I'm going to end that poll. I'm going to share your results. And now you'll see there are lots and lots of different results here. Let me see if I can move the page. Here we go. So I'm sharing our results, but I also will talk to you. So 88% of you said a 60-year-old with a pre-existing lung condition who lives in Connecticut, and you'd be right. Same thing for those who said, the 94% of you who said a 66-year-old with no pre-existing health conditions who lives in Connecticut, a teacher who lives in Connecticut, 84% of you got that right, a nurse who works in a hospital who works in Connecticut, 96% of you got that one right, 42-year-old veterinarian, not currently eligible in the state of Connecticut, and a 57-year-old who's the primary caregiver for his 92-year-old parent who both live in Connecticut. Yep, that's correct, 86% of you. And then the 80-year-old who lives in North Salem, but whose daughter lives in Connecticut. So 31% of you thought they might be eligible, but they are not eligible in the state of Connecticut. Okay, I'm going to move on to the next slide, and I'll show you what the criteria is. So who is currently eligible? And again, this all changed beginning yesterday. So healthcare personnel, medical first responders, long-term care facility residents and staff, individuals 65 and older, and then starting March 1st, educators and childcare providers, and individuals who are 55 and over. So what we're seeing in the future of this is that moving forward, there are no more occupational groups. So early on, we were talking about doing things by occupational group. So if you're a frontline worker, essential worker, if you're a If you're working in different settings, whether it's education or whether it's grocery stores or retail stores or restaurants, there were occupational groups that were ranked in terms of their exposure and their risk, and they were going to be prioritized for vaccination. The state of Connecticut said no more. Same thing with pre-existing conditions, too complicated, only going to create red tape. So moving forward, they're doing age only. So based on that timeline, they feel that we're going to be able to vaccinate more people more quickly, which means that ages 45 to 54 will tentatively open March 22nd. Age 35 to 44 will tentatively open April 12th, and all age brackets will tentatively open on May 3rd. And of course, this will all be helped by the fact that Johnson & Johnson was recently approved, which means we will have much more vaccine supply than anticipated. Here's another comic for you. This is a space shuttle. How long will it take to get to Mars? And then someone else is saying about 7 months, or about the same time to book a vaccine appointment online. It definitely can feel that way. So another thing that's new beginning yesterday, effective March 1st, all phases will require a form of verification to confirm eligibility at the time of their appointment. For anyone in phase 1A, congregate and educational childcare settings, individuals need to provide an employment ID badge, a payroll stub, a business card, or a letter from their employer or other documentation. Again, that shows that they're working or living in the state of Connecticut. All other individuals are eligible due to their age bracket, and they need to be asked, they will be asked to provide an ID or other documentation demonstrating their date of birth or age. So if you don't have a driver's license or a state issued ID, you need to have another form of ID demonstrating your age that you can bring to the vaccination clinic. So who decides the eligibility? It's not the vaccine clinics. It's not the physicians. The eligibility is determined by the Advisory Committee on Immunization Practices, or it's called ACIP. It was formed through the CDC. And so CDC, as we know, is a federal agency. So the federal government, or the ACIP, makes the recommendation. And then the states each have the option of tailoring or adapting the recommendations for their population, which includes the timeline. That's why we saw our neighbors in New York were incorporating the 65 plus way before us. And that's why it is so confusing to figure out who is actually eligible for the vaccine, because it does vary from state to state. And as of right now, Connecticut is the only one who is doing age-based rollout, but I wouldn't be surprised if we see more of that in the time to come, in the coming weeks. So I'm going to do just one more poll, and then I'm going to let you weigh in. If you were a member of the ACIP and you have a limited number of vaccines, which of the following people should receive a vaccine first? So it shouldn't be multiple choice. You should only choose one. I think it's letting you choose multiple, but please only choose one. Our choices are a 98-year-old living at home, an elementary school teacher, a 26-year-old with a heart condition, a pre-existing health condition, a 55-year-old with lung disease, a healthy 67-year-old. Who would you choose? Again, only choose one, please. I'll give you another 5 seconds. We've got about 82% of you have voted already. Okay, so I'm going to share these results with you. So it's a pretty, I would say almost a pretty even split here. So 22% say the 98-year-old living at home, 17% say an elementary school teacher, 20% say the 26-year-old with a heart condition, 37% of you say a 55-year-old with a lung disease, and a healthy 67-year-old is only 3%. So this is what the only reason I'm doing this poll right now is just to show you how difficult it is to make these decisions when you have a lot of people at the table. The fact of the matter is everybody is deserving. I never, ever, ever want to find myself on the seat at that table making these types of decisions and these recommendations, but this is what the ACIP was tasked with. And this is what every state government and governor is then tasked with within their own state. And as you'll see, everyone's got different interests and different ideas as to who should be prioritized, which is why when you look at things from a number game and how to upset the least people, if you look at death and serious hospitalizations, it really is correlated with age. And I think that's ultimately why the governor decided, let's forget the occupational groups, let's forget all this other stuff. Let's really just focus on getting the most vaccines to the most people. And that's what he's doing. So I don't say I'm agreeing with everything. I'm just saying this is probably, this is not an easy decision. And now you kind of get a sense of what that is. So what does that mean? Just again, please be nice to your friendly local vaccinators. It is not in our control. We can't make exceptions. We think everybody is deserving and would love to vaccinate everybody, but it's truly a matter of supply and demand. Prior to this week, people were able to schedule appointments but they weren't actually eligible. And so there still might be a possibility of that. And just because you can schedule an appointment doesn't mean you're eligible. So please be mindful. If you're not eligible, don't schedule, because you will get turned away at the clinic. You are required to bring some proof to demonstrate your eligibility. Again, be kind. So how do you schedule a vaccine appointment? There are a few ways. The computer uses either VAMS, the Vaccine Administration Management System, which I'm sure many of you are familiar with. We love to hate it. It's pretty bad, but it is getting better. I'll give them that credit. And then separately, the hospital systems websites, actually many major, and I think I have this listed on the next page, many major hospital systems have their own websites and schedule appointments outside of VAMS. Same thing with pharmacies. On the phone, you can call 211 for information, and Connecticut has a vaccine appointment assist line, and it's available 7 days a week from 8 a.m. to 8 p.m. And then most towns have set up helplines as well to help field those phone calls. So currently the state of Connecticut is endorsing VAMS as the platform for clinics to schedule, record vaccine recipient data, bill. Again, large hospital systems and pharmacies have permission from the state to use their own scheduling systems. So you can always check places like Yale New Haven, Hartford Health, and Stanford Health. Just important to note, Newvon's Health, which is Danbury Hospital, New Milford, Norwalk, and Sharon, they're still using VAMS. Pharmacies are new to the game, and they're also doing their own scheduling through their own websites. So you have lots of options. Don't rely on VAMS only. If you can't use a computer, call the Connecticut Appointment Assist line. And VAMS is getting better, but it's changing. You might not actually need the unique email address anymore, but you do need to have a certain level of savvy when it comes to emails and websites. So what to know as time goes on, this process will get easier. Please be patient. Keep checking back on VAMS for more appointments. They will be added. Fridays and weekends will likely yield more appointments as clinics learn the amount of vaccine that they'll receive for the following week. If you get an appointment for 3 weeks out, keep it and go. Don't worry about canceling it and finding something sooner. There is simply more demand than there is supply at this point. Again, remember to get your second doses. Dr. Hale talked about that. It needs to be the same as the manufacturer that you got the first. Most places will help you schedule your second dose appointment while you're in the observation area. Remember, Johnson & Johnson's an only one-shot deal. And then keep calm and wear a mask, even after you're vaccinated, and wear it correctly. It shouldn't be loose fitting. There shouldn't be gaps. It needs to cover your full nose and your full chin. And double masking is great when you're out in public. So a disposable and a cloth mask. Again, it should have a tight fit. 2 disposable masks really doesn't improve anything. So a disposable and a cloth mask is the way to go. And then I know I'm running short on time here, so we're gonna stop this quickly, and then let's see. And then I think we wanted to pull on Doug Hartline quickly. He's going to join us by audio, and he is going to talk a little bit about what the health department in Reading is doing to help the town. Let's see if we can get him on the line here.
Doug, he's with us. He needs to unmute himself. And I don't know if he's having difficulty. He had some difficulty with his connection.
Okay, so why don't I do this? Why don't I pull up Dr. Hale again, and we can start with some of the questions that we've received.
Yeah. I was looking at them here as you were finishing up, Laura. One of them, if the mRNA vaccines are effective with the variants, does that mean Pfizer is not? So Pfizer is actually one of the mRNA vaccines, Pfizer and Moderna. Those are felt to be effective with the variants. The Johnson & Johnson, the non-mRNA based vaccine, the trial actually took place within South Africa and Brazil. So there is a very good expectation that because the trial participants were from those areas where the variants were emerging, that there still will be efficacy against the variants for the Johnson & Johnson. So right now, assume that all currently available vaccines have some efficacy against the variants, and whether or not that efficacy is somewhat reduced, still some protection we would consider better than no protection.
Thank you, Dr. Bell. I also see a question about people, whether a person with allergies should take a couple of Benadryl tablets before getting the vaccine. Is there any clear guidance on that?
I mean, well, the guidance right now suggests against any pre-medicating of any kind, and that includes with Tylenol or Advil so that you don't feel the arm pain. You know, and exactly why, you know, whether it impacts the ability of the vaccine to do what it needs to do once it's in your body to develop the effective immune response down the line. We don't know if it would impact that all, but certainly if someone had severe allergies, I would recommend bringing your EpiPen with you. I wouldn't necessarily pre-medicate with Benadryl because in some cases the allergic reaction can be delayed, and I would be concerned that if you pre-medicated with Benadryl, you would further delay your allergic reaction beyond the 30-minute observation window. And then God forbid you had gone home and all of a sudden you're having very severe allergy symptoms and maybe, you know, not have the help at the ready. Really, I don't think it's a good practice. And again, just because a lot of the people who are having anaphylaxis do have a history of allergies, not everybody who has allergies is having this reaction. So, you know, be prepared for it, but I also wouldn't 100% expect it just because you have allergies.
Thank you. We're getting a lot of questions that I can kind of answer. Mm-hmm. So for RVNA, they said if we know on Friday how many vaccines we're getting for the upcoming week, when do we post our calendar to show available times? A lot of people are sort of asking that. So it depends on the week. Sometimes the state tells us first thing in the morning. Sometimes they don't tell us until the afternoon. We then need to make sure we have the staffing. We need to make sure that we have the facilities available. So it could be anywhere from Friday afternoon to sometime on Saturday. So I don't have a direct answer for you, but generally by Saturday we have it posted, and it really just depends on how soon we learn of what our vaccine availability is or what our quantity is. People are also asking if they have a choice of which company's vaccine to get. The long and the short answer is no. But there are, you know, as clinics, when we provide when we post our appointments, we do put what type of vaccine we're providing. So if for whatever reason you do have a preference, you could theoretically wait to get an appointment at one of those clinics, but that is not recommended. There's been a lot of data. I know a lot of people are feeling like they don't want to get Johnson & Johnson because of those numbers, that 85% number versus 95. But there's been a lot of data to show if you have to wait a week to get a vaccine because you're trying to go after one that you like, it's going to make a huge difference in terms of when we could reach that critical herd immunity, that critical mass. And so the recommendation is take whatever vaccine you can get as soon as you can get it and do not wait. And again, it's important to note that nobody with the Johnson & Johnson vaccine, just like with Moderna and Pfizer, nobody was hospitalized, nobody died. So those are the two major things that you want to be thinking about. The 85% means that there's likely, you know, a few more people in the Johnson & Johnson group that are going to get some sort of moderate illness, but it's not going to kill you and it's not going to get you hospitalized. So not that we want you to have anything, But again, if you are waiting to get a vaccine to try to get the manufacturer that you want, there's a chance that you're contracting COVID, and COVID could cause you to be hospitalized or die or have long-term effects as a result of it. So we do not recommend waiting. And again, if Johnson & Johnson came out first, everybody would be singing from the rooftops that it's a great vaccine. Here's another, people are asking when they should check for appointments and about canceling appointments. So when should we be checking for appointments? You can check every day. It depends on how much time you have. Again, everyone's internal processes are going to work differently. So you absolutely can check every day if you want to, but don't go crazy. Like I said, a lot of the smaller clinics, like the health departments and places like RVNA, we're not posting too many things too far out because it's really hard to plan when you don't know what your quantity is. The hospitals, it seems that they're able to book a little bit further out. They probably have some arrangement where they know a larger baseline quantity than we do, and so they can post things further out. So definitely check there. Again, you can be on VAMS, and you can also check their individual hospital web pages. So for Stanford Health, Hartford Health, and Yale New Haven. So even if you have an appointment, it says someone here has an appointment in May. She's right, you can't look at the other appointments without canceling the appointment that you have, but you can look at CVS, you can look at Walgreens, Hartford Health, Stanford Health, Yale New Haven, and see if there's another vaccine appointment that you can get earlier. So again, I wouldn't give up appointments if you have it. May seems like a little bit far out. You probably can get something sooner, but you're guaranteed that appointment in May, so it's not a bad thing to keep. In terms of signing up for an appointment before your age group so that you're called early or when your group is actually eligible. So the state used to have a really quirky system that allowed you to sign up for VAMS in advance of your age group being eligible. It is no longer letting you do that. Again, what they're trying to do is prevent people from signing on for appointments and showing up for appointments that they're not actually eligible for, because that wastes vaccine. If we can't give you the vaccine when you show up at the clinic because you don't have the right identification, that means that's a vaccine that we're not giving that day. And when that happens in quantities, that can be difficult. Okay, let's see. So somebody is writing about first and second dose vaccines. The way that the quantity the way that the process works is that the state automatically allocates second doses where they gave their first doses. So if I gave 200 first dose vaccines today of Moderna, 28 days later, they're sending me those 200 doses again automatically without requesting them, so I could vaccinate those same people and give them their second dose. So if you got your first dose somewhere and they didn't schedule a second dose appointment for you, you should reach out to them and see if they can accommodate you, because they will have that inventory for you. Alternatively, you can go on VAMS and see if there's a second dose clinic after your 28 days, and then you can sign up for that as well.
I see a question here, Laura, about quarantine and travel once you've been vaccinated. And the current quarantine recommendations are that if you have been fully vaccinated, again, for Pfizer and Moderna, that's 2 doses. If you have been fully vaccinated and you've been exposed, that you do not actually need to quarantine. They have not mentioned anything with regards to travel. Many of our travel restrictions, as you probably know, are government driven as opposed to medically driven. So whether or not that will change remains to be seen. It's a little bit fuzzy of an area, I think, because as we've been told and as we know, actually having the vaccine, we do not know has been proven to prevent our ability to spread it if we do contract it or carry it. So even the quarantine advice, I was surprised to see that come through, but if that does stay, that you don't have to be quarantined after an exposure if you've been fully vaccinated, I suspect we can anticipate the travel recommendations changing, but that's really not in our hands.
Yeah. And again, I think people are having questions, but remember, you know, in terms of travel quarantines and so on and so forth, remember there's no data right now showing that just because you have the vaccine, you can't contract it and spread it to others. So until there's more research and data out there, it's unlikely that these recommendations are going to change, because you can travel somewhere, pick up the disease, the virus, and bring it back here. And that's what they're worried about. So even if you yourself are not getting sick from it, you might be bringing it to your workplace or to your school or to your grocery store. And so that's where those quarantine measures are coming from. In terms of VAMs, we're getting a lot of questions. So the state, we can send, maybe what we can do is send a link here, but Connecticut.gov, ct.gov has a link on it that allows you to register for the VAMS website if you're 55 plus. And if you are, it's a two-step process. So the first step is it's sort of like a pre-registration through the state of Connecticut website. And then once they approve that you are actually 55 and eligible, they send you a second email. And then you go in and you have to sign in and actually register for VAMS. And there's a great video actually on the Ridgefield, the town of Ridgefield's website, and the town of Wilton also has it, that shows you step by step what that looks like. And you could go to the RVNAhealth.org website as well. We have a link to that video. It's a two-step process. So one, you pre-register on the Connecticut.gov page. Once they approve you, they send you a second email. You go in and you actually have to log on to VAMS, and they ask you a question at the beginning that trips everybody up, which is, are you already registered? And the answer is no. So you have to put in that no, you're not registered, because you pretty much just pre-registered, and then you're able to fill out the rest. Once you're on VAMS, you then have to look, you know, you put in a zip code, you do a search, and you try to find an appointment. We're getting lots of questions. You know, I'm on here, I don't see any appointments. The reality is right now, March 1st opened up to hundreds of thousands of people, and we don't have hundreds of thousands of appointments. So there aren't going to be appointments this week, in all likelihood, but there will be more appointments in the coming weeks. And again, with Johnson & Johnson coming onto the market, there are going to be more appointments coming forward, which is good.
Laura, I don't know if you saw, we have Doug now live on audio.
Okay, great. Doug, are you there? No. Can't hear him.
Doug? Oh, he was there. And
He
now
was there. All right.
connected again. My apologies.
No, that's
Sorry.
okay.
Yeah.
So in terms of, I'm looking at some of these other things, people are concerned about the state moving through to the other groups and whether they'll be, the older folks will be prioritized. The fact of the matter is, it is a first come, first serve type of program. So not necessarily. We still have 75-year-olds who have not been vaccinated. What the state is encouraging us to do as smaller clinics is to really make sure that we're reaching out to those folks who maybe can't use computers, who can't easily access clinics, might have transportation issues, so on and so forth, and then really make sure that they're able to get in. But yeah, when the 45 to 54-year-olds come on the scene, if you haven't gotten a vaccine yet, they're in the same pool as you are, looking for those same appointments. So the sooner, you know, ideally what the state is going to do, and I can't promise this, but they're going to be looking at vaccination numbers. And if they're finding that everyone is using all their vaccine in full each week, they're not going to open it to the next group yet. But when they start seeing that there's a lag where we can't use all of our vaccine, that shows that the people in our areas in that group who want the vaccine are kind of spent. Because remember, not everybody is going to want to get the vaccine. And so then they'll start opening it up to the next group. So that doesn't mean it's 100% done. It just means that they want us to be rolling this out as quickly as possible and getting all those appointments. So I think Doug is back on. Are you there, Doug?
Hi, Laura. Can you hear me?
We hear you now.
Oh, thank goodness. Sorry for the delay. I'll just be quick and kind of mention the Reading aspect of things. We've been partnered with the town of Bethel and been holding clinics up in Bethel. So Bethelites and Reading residents have been going up there. And we've also been recently holding clinics at the Reading Community Center. And the key message is that you register through the Town of Reading CT.org website. On the front page of that website, there is a box down below that you click on. It says pre-registration 55 and up, and you sign up in there and put in all your information, and you click. It tells you success, you have signed up, and it basically puts you on a list. And we go down that list in the order in which people have signed up. And as Laura has mentioned, the list is very, 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 very long. And we just have to be patient, as the governor always tells us every time. And we'll get to everybody. And we do find that it's been a great cooperative effort where we find the hospitals have helped people. We have CVS, Walgreens, and Richfield VNA. They've all been providing vaccinations. And as Laura has mentioned, sign up for everything you can and take the most, the soonest one you can possibly take. And so that's the Reading aspect of things. I'll take it back.
All right, thank you, Doug. And I think he answered those questions that people had typed in for him about what that process looks like. So thank you. Okay, so I see that we're over time. You know, feel free to reach out to us, ask any questions at any point. I will ask that the library send to all attendees the link to pre-register for vans, the link to RVNAhealth's website, in case you have any questions about our vaccine administration. We also have an on-call list each day for any extra vaccine that we might have at the end of the day, whether somebody didn't show up for an appointment or wasn't eligible, or some vials actually have extra doses. So we do keep and somebody just typed that in, we do keep what we call an on-call list, and it resets every day. So if you're available that day, you have to log on to our website and you have to sign up for that on-call list. And I think it actually resets. We pretty much do it at midnight. We have some crazy people who want to stay up, or maybe they're just, you know, they're not early risers. They stay up late and they put their names on at midnight, and they're the first on our list. But again, we always go by eligibility group first. So if a 26-year-old was up at 12:01, first name on their list, and then someone at 7 a.m. is 56, the 56-year-olds will get the priority. So anyway, that's how it works. Most places do have some version of an on-call or wait list, again, just to make sure that we're using all of the doses. But I want to thank again the Mark Twain Library for having us, and the Reading Commission on Aging, and we really appreciate everything that you're doing.
Laura and Dr. Hale, thank you for being with us. Doug, thank you for making it on. I do want to let everybody know that we did record today's program, and so in several days it will be up on our website, and you can view it there to kind of go back and review any information and let your neighbors know that they can see it there too. But thank you so much for being with us and sharing this valuable information.